Welcome, everyone. Thank you so much for joining us today. My name is Dr. Louise Ivers. I'm the faculty director at the Harvard Global Health Institute. I'm delighted to welcome you all to HDHI's virtual series called Coffee Sessions. This series is designed to explore and discuss the role of partnership and collaboration when working to advance global health equity. We welcome you to mark your calendars on the last Friday of every month around this time. This is our last session of this year. The session is being recorded through Zoom, so the recording will be made available on our website and YouTube page in the coming days. We plan to have time towards the end of the presentation to answer your questions as attendees. So if you have a question, you can submit it through the Q&A feature on the bottom of the screen, and we'll do our best to get to that. So with that, let me please introduce our speakers, and they're all very accomplished. So this is a high-level summary of their bios. We have Dr. David Duong. He's the director of the Global Primary Healthcare at Harvard Medical School's Center for Primary Care, and in the Division of Global Health Equity at Brigham and Women's Hospital. His work covers primary healthcare training, system strengthening, co-design, policy, and advocacy across Southeast Asia and in the US. He leads research and has published extensively on healthcare systems, including now co-leading the Lancet Global Health Commission on People-Centered Care for Universal Health Coverage. He's a primary care physician, a member of the World Health Organization's Technical Advisory Group on Integrated Clinical Care, and previously served, amongst other roles, on the World Economic Forum's Global Future Council on Health and Healthcare. Dr. Janus P is a gastroenterologist and a transplant hepatologist, a researcher and a hepatitis advocate. He's head of the Liver Research Program at the University of Philippines National Institutes of Health and serves as assistant to the Vice Chancellor for Research at the University of the Philippines, Manila. He's a consultant in gastroenterology and transplant hepatology. He's published more than 70 research articles, is on editorial boards of a number of journals in his field. He works with the Department of Health, World Health Organization, and numerous professional societies on hepatitis awareness campaigns and prevention and control in the Philippines. Dr. Todd Pollack is Director of Implementation Science for Global Primary Healthcare at Harvard Medical School Center for Primary Care. He's an infectious diseases doctor and assistant professor of medicine at Harvard Medical School and the medical director of the Partnership for Health Advancement in Vietnam, a Harvard University global program with a mission to improve healthcare in Vietnam. His work focuses on strengthening primary healthcare systems and on improving access to quality and equitable care for people living with HIV and viral hepatitis. Dr. Pollack co-leads the Lancet Global Health Commission on People-Centered Care for Universal Health Coverage. We're absolutely thrilled to have you here today to talk about your work and your partnership. And I'm going to pass it over to David to get us going. Thank you so much.
Well, thank you so much for that warm welcome, Dr. Ivers. And myself and my colleagues, Todd and Janus, are so excited to be here to share our perspective on collaborations and partnerships for global health equity with all of you. So thank you so much to the Harvard Global Health Institute for hosting us today and hosting us for a conversation. So we're hoping that this can be a little bit of an informal conversation where the three of us will start and just share our journey and our perspectives to the development of our partnership. But before I do that, and we start with that, I just wanted to kind of give a brief overview on our multi-country, multi-institutional partnership that spans the global South and the global North and between the global South as well. And it's somewhat of an interesting partnership because, as Dr. Louise Ivers introduced, I'm a primary care doctor. So whenever I think about hepatitis, I get kind of nervous, especially interpreting all of those serologies. And here in Boston, I always kind of call a friend and call Todd up and be like, so what does this mean and what's the next step? So when I read and learned, as I was as initially it was Todd and I thinking about a viral hepatitis project, I was like, wow, can it really be done in primary care? Even though the WHO has called for, starting in 2014, a primary care strategy, or rather a decentralization of hepatitis care and treatment down to the primary care level. And then I further learned that the viral burden, the global burden of viral hepatitis is quite large, so large that if we keep the status quo, by 2040, deaths from viral hepatitis will exceed that of HIV, tuberculosis, and malaria combined. And that was pretty stark. That was a really stark number for me. And where that is the highest burden is in the Asia Pacific region, where this project is located between Vietnam and the Philippines. So I already shared that the WHO and country governments have committed to or called on a global viral hepatitis elimination by 2030 through a decentralized approach focused at the primary healthcare level. So that over the last 4 years, since 2021, that's what Janus, Todd, and I have been working on, along with another now faculty member at HMS, Bethany Holt, along with our amazing team on the ground. And the project itself really focuses on a co-design approach with people living with hepatitis and their carers and their communities, bringing hepatitis care to folks which we would consider the right care at the right place at the right time by the right team in the right way. There's a lot of rights, and that's and we definitely had a lot of wrong missteps along the way. But I think that we all learned a lot about it. And where the project is at right now is that we are in our second implementation year of a brand new model of care in places in Vietnam and the Philippines at the primary healthcare level where there was no hepatitis care and treatment in 2021. And we've done 1 year of implementing this model of care that we designed with people with living with hepatitis. And now we are in our scale up year where we're scaling to new cities and new provinces before the government takes over the program. But today's conversation is really about the partnership that came to be. And to chat more about that and to give us further more background, I'll turn it over to my colleague, Dr. Janus Ong. And maybe, Janus, maybe you can describe a little bit about the hepatitis situation in the Philippines for us, and then also how you came to this project. Oh, Janus, and you're on mute.
I'm so sorry. Thank you, David, and thank you for giving that overview of our project. And thank you, Louise and the Harvard Global Health Institute for this invitation to be a part of this Global Health coffee sessions. It certainly is an honor and a pleasure to share our experience. Viral hepatitis is a significant problem in the Philippines, in particular hepatitis B. The seroprevalence is a moving target, and maybe this year we'll have a better idea, and it's probably going to be around 4.5%, the weighted average, and about 5 million individuals with hepatitis B. A smaller number with hepatitis C, maybe about 400,000. But regardless of that, viral hepatitis is still the #1 cause of liver cancer in the Philippines, which is a major killer. It's the second leading cause of cancer deaths in our country after lung cancer. And while it seems like, we've been a country that's signed on to the World Health Assembly resolutions, which has happened twice, very few in the country have been diagnosed and have been treated for their condition. And so I think given that burden of disease, it is really important for us to find solutions to address the problem of viral hepatitis. Thank you. And so the collaboration, was it another question or?
Yeah, yeah.
Or
How
how I,
this collaboration
how I
came
got
to?
involved. Yeah. Well, I've been involved with viral hepatitis work for, I think, close to 15 years. As I came back from the US, I started working on advocacy for viral hepatitis. And so through those years, I've learned that the problems with viral hepatitis requires a a, a a a package of solutions in order to solve it. And in a country that's like an archipelago, we need to have a primary care approach to its management. So that's how I've been involved with viral hepatitis. Unfortunately, we couldn't really find funders that would, be interested enough in such large, ambitious projects to find solutions to the problem in the Philippines.
Thanks,
Thank
James. Let
you.
me jump in here. I also want to thank Louise and the Harvard Global Health Institute team for inviting us. Let me just explain a little bit about how the partnership first came together. So as you might have heard from my bio, I personally and the Harvard community has had a long-standing, more than 20-year partnership in Vietnam. And so when we were first starting to work on putting together a project related to response to viral hepatitis, as David mentioned, we certainly looked in the Southeast Asia and Western Pacific regions where the burden is the highest. And we had a donor partner who was in discussion with us at the time. And they were certainly, we were interested in doing it in Vietnam, as we already had doing the project in Vietnam, as we already had a lot of partnerships and experience there. And the donor was happy with that as well, as they saw our, they saw the conditions for positive outcome from the project working in Vietnam. But David and I, we were thinking that we wanted to expand into other areas as well. And, one of those reasons is because about the burden, as David mentioned, we wanted to have a broader impact. And a second reason is that we felt it was important in this area because it's about health systems work and health systems redesign to have an opportunity for cross-country learning. And of course, there could be cross-country learning between the US and Vietnam if we were to work only in Vietnam. But those systems can be quite different and quite far away. So we thought to have South-South collaboration and a regional collaboration would really be important for bringing success to the project. So we were interested in looking at other countries in the region. So, we used our networks to find other good partners. And I had done some work in the HIV area, very little, but a little bit with a partner in Philippines. So I reached out to that person to find out, who's working in viral hepatitis in the Philippines. And at the same time, we had also done some work in medical schools in Vietnam. So David reached out to university presidents in Vietnam to find out who might be a good partner in the Philippines. So we used our networks, and going in those two different approaches, all roads came around to Janus P. Everybody said he's the person you have to work with if you're going to work on viral hepatitis in the Philippines. So through those connections, we got to Janus, and we had arranged a call and had an initial conversation. And I just felt like from the beginning, we're all on the same page in terms of what were the needs and what the impact of this kind of partnership could bring to the Philippines and also to the region. And the other thing I think was important about this partnership is that the three of us on this call, and of course, there's so many other people working on this project, we all have slightly different expertise and like complementary expertise as it pertains to this project. So I'm trained in infectious diseases, Janus is a hepatologist, and David is a primary care physician. So these things, you know, our partnership is really very complementary. And I think that also is part of the reason it was a success. So that's how it kind of all started with that first call. And then after that call, David and I made a trip to the Philippines to meet Janus in person. And then Janus took us around, Manila to meet, sort of a lot of the VIPs that, we needed. It was important to get their approval, kind of, their sort of consent for the project and for the partnership. So those at the National Institute of Health and those at the university leadership where Janus works. And we got to meet Janus and his team, and it was really a wonderful trip. And we started to broaden the partnership from that initial trip. So that's how it started. Maybe I can pass it back to Janus, and he can talk a little bit about the partnership development from his perspective, or from the perspective of his institution.
As Todd had mentioned, I think I got to learn about the project and the interest from Harvard Medical School through the contact of Todd in HIV. And she contacted me, and she said that Todd was going to reach out. And so after the speaking with Todd, I felt that it was such a great opportunity to partner with like-minded individuals, and bringing in the experience and the breadth of knowledge that the David Center has on primary care. And because I believe that in order for us to eliminate viral hepatitis anywhere, I think, and especially in the Philippines, we have to bring it down to the primary care level. And that to have someone approach us who has a very nuanced and very extensive understanding of primary care approach to problems of health, then that was, I felt, really a great opportunity to partner and maybe find solutions to our problem here. Yeah, so that was, to me, I think, the most important selling point of our conversation.
Yeah, and I'll just pick up on that, and I have such this vivid memory of Todd and I landing in Manila. It was 2021. Everyone was still masked. Well, in Vietnam, people were not masked, but then in the Philippines, in Manila, people were still masked. And there, it was Janus, myself, Todd, and another faculty from the University of Manila, kind of traveling around and, like, as Todd said, meeting all of the higher ups. And we were just like, we spent like 2 days in a van, because if anyone's ever been to Manila, it's like, so it's just like traffic, right? And we got to really know each other a lot through shared meals with each other over those 2.5 days, as well as just time in the van, and then sharing about ourselves and our motivations. And I think that was one of the that was such a critical bonding point for the three of us, but also other members of our team. And it allowed us, when we spent that time in person, that I just felt like you could never do over Zoom, or it would be very difficult to do over Zoom. We really came up with a shared vision, right? And as Todd said, like, the three of us came from different perspectives, but I think that we shared this vision of that we need to get this care, which we have all of the diagnostics and all of the treatments for, closer to people. As we were sharing, and Todd was sharing his experience in Vietnam, and Janus was sharing the experience, and we were learning the experience in the Philippines, we just all felt like, these experiences are very similar, and there can be similar approaches adopted. So I think that shared vision was really critical. And then the alignment of that common purpose, again, of basing any project that we were to design together at the primary healthcare level and using the voices or in collaboration with patients and people with lived experience and their families. And when the three of us aligned on that, I think that everything else just kind of went, it was very natural, because then when we started to put it together, the team in Vietnam, the team in the US, and the team in the Philippines, that's what the three of us kind of led with. And that was very clear from the beginning that that was the underpinning current or the motivation of this project. And then I would say that I think we did really intentional team building at the very beginning. Team building meaning bringing the three teams together, also team building online, putting up an internal website first. One of our other project leads, Bethany Holt, like put up this mural board with everyone's pictures and then like fun facts about people. And it was just really nice to go through that and get to know folks on a personal level. And as the years have gone on, I felt like the project team has gotten, like we've become this big family. And every single year we get together and it's like this amazing reunion because, because everyone really appreciates one another, respects one another, and also, again, has this shared common goal and purpose. And that led to trust. And I think that's like another component that this, it was very intentionally built in, and we intentionally thought about it from the beginning was, how do we build trust amongst each other as we work across cultures, across different healthcare systems, across continents. And a part of that, again, was getting to know each other both on a professional, but then on a personal level. And then it was about transparency and saying, okay, this is what we think the project should focus on over the next so many years when we've come up with the project, when we co-designed the project with both our teams and the people with lived experience. And then and then being very transparent when things just did not happen the way that we initially planned or envisioned it. And then it was this kind of co-design and co-production of that solution together. And then talking about co-design and co-production, that was a third area that we really focused on, was the involvement of communities and people living with hepatitis and their experience, and also valuing every single person on the team and their input. So Janus was able to recruit community and family physicians along with social, like an anthropologist. We were able to have community organizers in Vietnam, etc. So I think that it was such an amazing, diverse perspective that then from that diversity of perspectives, we were able to develop really diverse solutions and metrics for what success meant. And we go through this exercise now where every year we say, okay, what is our statement of intent for this year? And the entire team participates in that, right? So for last year, our statement of intent was that all patients entering our program would be linked to care, and we wanted that goal to be 80%. And then we were just all in Hanoi together in November, and we kind of co-developed a statement of intent again. And that way everyone has this like shared vision of what we're working towards. So that was, I think, 3 critical areas that we focused on to intentionally build up our team. And then lastly, we celebrated, and we celebrated a lot. We celebrated small wins, we celebrated big wins, we celebrated when a paper got published, we celebrated when someone got an abstract published, and that just that was really amazing for both the 3 of us, but also for the team members and elevating people's work. So those were kind of the 4 kind of ingredients in terms of how we structured the partnership from the beginning. And I'll pivot over to Todd to see, Todd, if you wanted to add on anything to that, and what have you learned from the collaboration and what opportunities this partnership has led to?
Yeah, thanks, David. I did want to pick up on a couple of things you said. One thing that I learned, I would say, from this partnership is that partnership, building a strong partnership takes time and effort. It doesn't just happen. And like David mentioned about the intentional team building. So David and Bethany, one of the other project leads, really sort of instituted that in this project. And I have to say, like, it was a lot of meetings and a lot of time, sharing about ourselves in different ways. And, I wasn't sure that, we weren't getting to the meat of the sort of health issue at the very beginning, and for me, that's like, as a very technical oriented person, I was like, okay, let's talk about hepatitis. I have a dog and a cat, but let's talk about hepatitis. But it really was important, and I learned that from this. I mean, it was the building of the trust among the team members is so important when problems, which inevitably will happen down the line, occur. So I thought that was so important. And I think another thing that I learned was about the importance of sharing opportunities. So like during the project, there were many opportunities that came up, like speaking invitations, abstract submissions to conferences, traveling to conferences, papers, things that, people working in academic field want to participate in. And I felt like we did a really good job of sharing those opportunities among the different teams. So there's 3 of the teams of Vietnam's not necessarily represented us here today, but among the 4, the 3 different sides. So some conferences Janus presented the project at, or his team members, and likewise others. And I felt like that was important in terms of building the partnership and continuing to build trust and motivating people. And I felt like it created like this positive feedback loop of opportunities and impact. So like the more that we were out there, different team members, that created more opportunities. So for example, in Boston, we like engaged with WHO at the sort of global hepatitis level. And, we started, here, just sharing with them. And then, that sort of, Janus had his own connection to WHO as well. But then, Janus ended up on the guideline committee for the WHO hepatitis B global WHO guidelines that were recently released. And then also like this project also led to the Lancet Commission that, David and I are co-leading as well. So I feel like it was just like more and more opportunities were coming out of this partnership. And I think it's just the evidence about like how strong a partnership it is and the impact that it's been having. And also other grant applications. So we're waiting to hear next week about something that would continue to expand the work that the 3 of us collaborated on as well. So that's some of the things I learned. Maybe I can hand it back to Janus in the couple minutes we have left to hear about his perspective on the impact of the project.
Yeah, I think I echo everything that Todd and David had said. I just wanted to add that for myself, I think, and for the Philippine team, for myself, I think one thing common among the 3 of us is our public health background. I got a degree from the other public health school that cannot be named. So I'm just I think I was able to apply my learnings from there, and then learn from the project and the other team members, as well as from our other country collaborators in Vietnam on health system strengthening, which was very exciting and interesting for me as well, to relearn that and maybe use that to contribute to national growth, to our to nation building as well here in the Philippines. And of course, our team, I'm very thankful to have such a great team on the ground in the Philippines. I'm sure they echo what I said, that we all are learning a lot from the collaboration with the US and Vietnam. And I think one of the things that really can bring us all together was, of course, remember Todd and David, karaoke. So we always had karaoke to fall back on.
Just don't ask us to sing right now.
Yeah, I feel like that's a really great invitation to me to pop back on. I love it. But I'm not going to sing. You don't want that. But this has been really fantastic. Thank you so much for sharing all of this. There's so many areas about the partnership and the project that I think I'd love to spend the last kind of 15 minutes that we have. We have some questions from the audience, but maybe I'll start. You talked about this deliberateness on the team building, and Todd, I appreciate your honesty in being like, oh, wait a minute, like, can we talk about hepatitis? Because maybe not but it strikes me that this is such an important part of collaborations, and especially in 2024 era where we do so much, even when we're in the same city, we do so much online. And yet, like, that time in the car, that time having meals together or doing karaoke or breaking bread together, that part takes time. It can be expensive both in time but also in expense, right? And then also sometimes our funders and our donors in global health, like, they don't want that time, they want to expedite. Could you talk a little bit more about how you have managed for yourself about that? Like, do you, or maybe even David, tell us a bit more about that deliberateness, because it sounds like you were building in the team. Is that something structured that you have done before, or were you just going off your own gut on how to do that? Like, how did you organize that? Would you say a little more?
Yeah, that's thank you. That's a great question. And I think that you're absolutely right. Like, in my experience, at least, donors they want to see results as fast as possible, right? And so it's really hard. And we were really fortunate to have an amazing donor, Gilead Sciences, so a pharmaceutical company. And we're from the very beginning, when I was talking about this with Gilead, I shared with them, I said, what, we can come in with an intervention from Boston, right? And apply it to Vietnam and the Philippines or any other country. And we'll just throw enough money at it and we'll get people screened and all that stuff. But we're not going to go very far. You'll get the initial numbers, but then that's going to be it. If we want to build in sustainability and government buy-in and all of that, like, we need to go slow at the beginning, and we actually won't come in with an intervention. So our project proposal to Gilead was 2 pages. It was a concept and it was a sketch of, like, these are the big overarching objectives. We knew we wanted to do people-centered care. We knew we wanted to engage in people with lived communities. And the Philippines has been an amazing country in which we've learned, and Vietnam has learned from. And even here in the US, I've taken that to my own primary care practice of how to engage patients and families in designing their own healthcare. So we knew we wanted, like, people-centered care, co-designed with patients and their families, and this was at primary care, because that's what the government's committed to, taking their own words from the WHA and the UNGA resolutions that Janus was referring to. But other than that, we're like, but we don't know what the intervention looks like, and we don't know where the bottlenecks are, and we don't know what the enablers are. So give us 18 months. Can you imagine it? 18 months to build the team, to build the intervention. But now what's happening? After 18 months, and we built the intervention, co-designed and built the intervention together, and got the government in at the table as well. And some of them were there karaokeing with us too, and in the car with us as well. Like, now they're scaling it by themselves, and they're like, okay, we're going to procure all of this. Like, we want a part of this project, and this is going faster than, honestly, than we would have imagined after 1 year of implementation, full implementation, after the 18 months of co-design and team building. And that was really amazing. So that flexibility from the donor allowed us to go slow at the beginning, but then now it's like kind of in warp speed, and that's been exciting to see.
Thanks, David. Maybe building on a bit team building and collaboration, and I'll direct this question to Janus. Like I see many layers of diversity here in this team. You know, there's the technical diversity of your technical areas of expertise. And then you talked about, I mean, there's a multi-country partnership. And then there's each of your individual lived experiences and where you've lived in the world or studied or, and then, but then also you're bringing in the teams in each of the places. And this gets to one of the questions, you know, the people, and you talked about the patient-centered care and the people-centered care. So how do you manage that multiple layers of engagement that you have to do? Because in global health partnerships, like there's the kind of PIs already have to kind of get along and figure out how to work together across time zones and places. But then you're also bringing in to a primary care level. It feels very complex. So how do you organize that in terms of decentralizing decision making, or how do you bring in those multiple layers? Or is everybody coming into your team building who's, you know, how do you manage that multiple layers of what I'm calling diversity?
I'm not, I'll try to answer it. From the within the Philippine team, I think our team is composed of a very diverse group. We have community organizers. We have, as David mentioned, an anthropologist. We have a primary care physician. We have community health physicians and experts. And so with that diversity, I think we are able to approach our partners on in the provinces, in the province of Tarlac, our site, and approach them at various levels, from leadership down to the grassroots, where we have the barangay health workers or the community health workers. So I think that's I think it's just so happened that we were able to bring that diverse group together. And I think when we have our global meetings, I noticed that while, you know, David and Todd and maybe I can be talking a lot, but everyone has this opportunity to talk and lead. So others will be able to lead, especially, for example, patient lived experiences, patient behaviors, cultural differences that can be certainly led better by a social scientist as opposed to some of us. So I find that there's equal opportunity to speak up and to lead discussions. Yeah.
Thank you so much.
I'll just chime in really quickly here, Louise, and I'll say, and here's a very concrete example. So we just had our global team meeting, and at that meeting, the purpose of that meeting was to generate our statement of intent for 2025, which is like, what is everyone working towards, right? So the statement of intent for 2025 landed on 3 kind of different statements that that people, you know, were very passionate about, you know, and what happened was we did this Iowa straw poll, right? Where like everyone gravitated to their statement of intent category that they really wanted. And then they started debating amongst each other across the groups, within the groups to refine it. And then they gave these impassionate speeches to get other people from other groups to come over to their group, and they voted with their feet. And at the end, it was just like we were laughing, we were crying, we were, you know, it was everything, but then everyone agreed on a statement of intent. And that type of collaborative process, I think, kind of resonates throughout the entire project of how not just decision making is done, but also resources are allocated and what's seen as important.
Oh, thanks. I think we need to learn more about your actual process. I love that idea of people moving with their feet and voting and talking out loud. It sounds really fantastic. Can you speak a bit, any of you, maybe Todd, you'd like to weigh in on, not because I think you're managing the conflict, but just because we haven't heard from you for a minute, but how have you managed any conflicts, or do, you know, surely at some point the conflicts arise, and I know, you know, the personal relationships are so important, and you talked about trust, and when you have that trust and you've developed personal relationships, you know, you're able to sometimes better manage conflict. Yet your collaboration is still quite young, 2021. like, have you had to deal with that? How do you try to do that? Anyone could speak, but
Yeah. Well, I can go first. Thanks, Louise. I don't. We haven't had. I would say within our teams, we haven't had major conflicts, but certainly there are some. And I would say that the key there has just been like open, transparent communication. And of course that's the answer I'm going to give. Because that's like what you would say on how you manage conflict. But I do think that is what we've done, and I do think that has been. We've been able to do that because of the sort of trust that was built, as we've already talked about. And also because of the transparency. And I think, sometimes with these projects, the budget can be an area of conflict. And I'm not saying that wasn't our project, but I do think that, Harvard is the prime on the project, so that the money goes first to Harvard. And in global health, there's a power dynamic with funding. As I'm sure everybody knows on the call, that's something, and it's so important to be transparent about the money, and be responsive to the partner's requests and needs. Because if you don't do that, the project won't be successful, no matter what. And so I think we did a good job of that from the beginning. So I think that sort of prevented any major conflicts in that area, but not just about the money, but I think that process is, set up for good success in other areas of potential conflict as well, and also allowed us to be able to be open with each other in other areas if conflicts came up.
thanks a lot. So we have a couple of the questions were about engagement with the governments and how government, engaged well, or how you got them on board. And then there's another question about similarities and differences that you may have seen between Philippines and Vietnam, or how those. I wonder if you could address that question kind of maybe together. They're not exactly the same question, but I'll put those to you.
Maybe I can answer to that. The first question on engaging the government. I think it helped that I've been working in this area for a long time, and have been on the technical working group for viral hepatitis, whether it's active or dormant or whatnot. I've been part of it for the last decade or so. And so when we wanted to start the project, of course, we needed the buy-in of the provincial government officials, even down to the municipal and city officials, as well as the regional and central health officials. And I have to say that the meetings were very cordial. They were very interested. We would present the project, present the problem, and they do recognize the problem and recognize that we needed help in terms of finding a solution. Sustaining it is a bit more challenging, but we are able to do that by constantly meeting with them. And we had a technical advisory committee, which included the provincial governor. And that was very helpful because at least the executive branch was well aware of what was happening with the project on the ground. So one problem that we encounter, that I think many other countries encounter also, are the frequent changes in leadership. And that is problematic, because then we would have to re-engage and orient the leadership about the project. But at least some of the people that remain to be supportive of the project. But it's not easy. It's doable, and it's a lot of hard work. Yeah.
I can add a little bit from Vietnam experience. So in Vietnam, at the province that we implemented or are implementing this project, we had an existing relationship with the Department of Health of that province based on previous work. So, building on previous work is always useful. So that relationship was easy, but, working in Vietnam, there's a lot of administrative levels that you need to go through to have permission to implement a project and such. So in that situations, like understanding the system is so important. So in that situation, our job was to partner with our trusted partner at the Provincial Department of Health to arm them. It was their role to go to the higher levels, they call it like the People's Committee in Vietnam government system. So our job was to arm the Department of Health of that province with what they needed to engage with the People's Committee. So it wasn't, we did not go to the People's Committee directly. So it's like understanding the system. And then the other important thing, I think, is that at the national level, so this was a project in one province or region in each country, but we wanted the impact to be national. So the important thing there was to engage the nationals, the decision makers, policymakers, and stakeholders as much as from the beginning and as often as possible, as Janus just referred to. So, for example, we wanted the social health insurance of both countries, but particularly speaking about Vietnam, to be able to use the outputs of the project and to advocate to them to include hepatitis care coverage at primary care level in the national social health insurance system. So we engage people from the beginning and ask them, what data points do you need that this project could potentially give to you to help you plan, for that in the future? So we did that at the beginning, and now we're collecting that data, and then we'll be working with them to provide them with information that may be useful for them to do their job, to help them think about whether hepatitis care can be fully covered by social health insurance.
Well, we're at time, so I have to wrap up, but I want to just tell you, thank you so much for sharing time with us today. Trainees are always asking, like, how can they engage in global health work in partnerships that are meaningful and equitable and impactful? And I think this is such a fantastic example, going from regional impact to national impact, working across countries, across expertise, engaging patients, community health workers. I really appreciate you all taking time to share with us today. Thanks to our audience for joining us and for being so engaged. As I said earlier, we will be posting the recording of this on our website in the coming days. So have a great rest of your day, everyone. Thanks, Todd, Janus, and David, for joining us. Really appreciate hearing from you. Thank you.
you.
Thanks.
Thanks, Louise.
Bye.
Thanks, everyone.
Thank you.